Good morning, students. Today we are having second topic in respiratory system, and today's topic will include the next subtopics. So 9 subtopics. Exchange of respiratory gases between alveolar air and blood of pulmonary capillaries, Dalton's and Henry's laws, factors affecting the exchange of respiratory gases between alveolar air and blood of pulmonary capillaries, mechanisms of coordination of ventilation and blood supply of alveoli, exchange of gases between the tissues and blood in the capillaries of the systemic circulation, transport of oxygen to blood, the oxyhemoglobin dissociation curve and factors affecting it, transport of carbon dioxide by blood, conversion of carbon dioxide into chemically bound forms, the Medullary Respiratory Center and its involvement in breathing regulation, Mechanoreceptory and Chemoreceptory respiratory reflexes, and the last one is influence of non-specific factors on breathing, caisson and attitude sickness. So, let's start. In order to understand mechanism of respiratory gas diffusion between alveolar air and blood in the pulmonary capillaries, it is necessary to consider two fundamental physical laws, which are Dalton's law and Henry's law. Let's consider Dalton's law. According to this law, in the gas mixture, the pressure of its every component is independent of the other component pressure. The reason for this is that the molecules in gases are so far from each other that they do not practically interact. Each gas in the mixture behaves itself as if there were no other gases. Therefore, the total pressure of gas mixture consists of the individual pressures of its components, which are proportional to the content in percentage in the mixture. These individual gas pressures are accepted to be called as partial gas pressure. For example, if the air pressure is 760 millimeters mercury at the sea level, and if we look at this table, we will see that oxygen content in the alveolar air is 14%, and we know that gas mixture in the alveolar air contains a saturated water vapor, which has a partial pressure of 47 millimeters mercury. This pressure is subtracted from the total pressure of gas mixture when partial pressure of the respiratory gases are being calculated. So by knowing all this, we have such equation. So 760 minus 47, which is saturated water vapor, multiply into 0.14, and we will have 100 millimeters mercury. So this is partial oxygen pressure in the alveolar air. According to Henry's law, dissolved in fluid gas content is directly proportional to the partial pressure of gas, which is in equilibrium state with this fluid. The dissolved in fluid gas molecules are creating partial pressure of this gas, which is called as gas tension. Diffusion does not occur if gas tension in fluid and its partial pressure above fluid are equal. If these pressures are different, the gas diffusion will be emerged until the equilibrium state will be reached. Respiratory gases penetrate the pulmonary membrane by diffusion due to partial pressure gradients of respiratory gases. Let's remember that partial pressure of oxygen is about 100 millimeters mercury. You can see on this picture. And its tension in venous blood is nearly 40. So you can see that partial pressure of oxygen in venous blood is 40. It can be noted that oxygen gradients is 10 times greater than carbon dioxide gradient. In spite of this, partial pressure of both gases are equalizing with the tension in blood, while the blood has been passing along pulmonary capillaries. The point is that carbon dioxide diffuses 20-25 times better through pulmonary membrane due to its higher solubility in membrane lipids. The penetrability of pulmonary membrane for gases has been characterized by such a parameter as the diffusing lung capacity. It is measured by the gas volume diffusing through pulmonary membrane per 1 minute when pressure gradient is equal 1 mm mercury. In the norm, the diffusing oxygen capacity is equal to 25 mm per minute, and carbon dioxide capacity is nearly 500 to 550. This index has been decreasing with age and during pulmonary diseases. The oxygen tension in mixed arterial blood flowing from lungs along pulmonary vessels is somewhat smaller than partial oxygen pressure in alveoli and is nearly 95 mm mercury. The reason for this is that bronchial venous blood is added to oxygenated blood flowing from pulmonary capillaries into systemic circulation, which is called shunting of the venous blood. The diffusion exchange speed between alveolar air and blood in pulmonary capillaries depends to a great extent on 3 factors. First, partial pressure gradient. Second, thickness of the membrane. And third is surface area of the membrane. So let's consider several typical examples illustrating this impact. So you can see on this picture some degenerative pulmonary diseases which decrease alveolar square where diffusive gas exchange occur. So emphysema is an example of such illness. Destruction of the alveoli means less surface area for gas exchange. So if we compare normal alveoli to the one in case of emphysema, we can see that surface area is decreased. So its effect, the diffusion exchange speed between alveolar air and blood in pulmonary capillaries. Next one, fibrotic lung disease. So we can see on this picture that the membrane become very thick. So thickened alveolar membrane slows gas exchange. Loss of lung compliance may decrease alveolar ventilation. Next one disease is pulmonary edema. So we can see that the thickness of membrane is normal, but fluid in interstitial space increases diffusion distance. Arterial partial pressure of CO2 may be normal due to higher carbon dioxide solubility in water. And in case of asthma, we can see that the thickness of membrane is normal, surface area is normal, but we can see constriction of bronchioles. So increased airway resistance decreases alveolar ventilation. All the given above examples have one common feature: low oxygen tension in arterial blood, which is called hypoxamia, which can be a cause of the tissue oxygen starvation, which is called hypoxia. Okay, next is mechanism of matching of alveolar ventilation and perfusion. The adequacy of blood supply, which is called perfusion, and alveoli ventilation has a great importance for normal diffusion of respiratory gases. At large, alveolar ventilation ratio to alveoli blood supply is equal to 0.8. This can be verified if alveolar ventilation is divided on cardiac output at rest state. However, there are regional features of pulmonary ventilation and blood supply in vertical body position associated with gravitation influence on hemodynamics. Although lung apex is being ventilated a little less than middle part and base of the lung, the blood flow here is much lesser than in located below areas. This is due by the fact that hydrostatic pressure of blood column, created by gravity force, counteracts blood pressure generating by right ventricle. The reduced alveoli perfusion in this region is a consequence. We can observe an opposite gravity influence on perfusion of the lung base as far as the pressure created by the heart and hydrostatic gravitational pressure are being added here. The middle part of the lungs is located at heart level, and gravitation in practice does not affect its blood supply. Taking into account these considerations, it is clear that VQ ratio in vertical body position is greater than 0.8 at lung apex and is smaller on the basis of lungs. If we considered ventilation perfusion ratio for single alveoli, it is necessary to note that it is being regulated by partial oxygen and carbon dioxide pressures in pulmonary tissue. In particular, increase of partial carbon dioxide pressure in alveoli, which is called hypercapnia, stimulates bronchi to dilate, providing them with air. As a result, ventilation of these alveoli has been increasing. On contrary, hypocapnia results in bronchoconstriction, which limits air delivery to such alveoli. At the same time, the arterial tone of pulmonary circulation mainly depends on the changes of partial oxygen pressure. As opposed to systemic circulation, hypoxia leads to terminal arterial vasoconstriction, and increased partial pressure of oxygen causes the arterial vasodilatation. It means that poorly ventilated alveoli get less blood than well-ventilated ones. The most of alveoli are being well ventilated and perfused in the norm. However, regional changes in bronchial patency in case of bronchitis, bronchial asthma, and others, or pulmonary vessel microembolizations, which decreases perfusion in the region, are possible during pathology. In these cases, the described above mechanisms minimize the mismatch of ventilation and perfusion. Thus, if part of alveoli isn't being ventilated, the partial oxygen pressure decreases in this area, what causes alveoli to constrict. So the result will be vasoconstriction of pulmonary vessels. And as a result, blood is redistributed to well-ventilated alveoli. If terminal arteriole is blocked, in case of, for example, microthrombus, the hypocapnia, result of partial pressure of CO2, arises inside the alveoli of blocked respiratory unit. As a result, bronchoconstriction of this respiratory unit occurs, and it will be temporarily excluded from gas exchange in favor of well-perfused respiratory unit. Therefore, vasoconstriction or bronchoconstriction in lungs results in the following. First, reduced blood supply of poor ventilated alveoli, and second is air and blood redistribution from damaged respiratory units to well-ventilated ones. Along with bronchial blood shunting, this is one more reason for the fact that the blood flowing out of the lungs has somewhat lower oxygen tension, which is 95 to 98 millimeters mercury, than partial pressure oxygen in the alveoli, which is 100 millimeters mercury. Main indexes of oxygen transport by blood. Oxygen entering into the blood is dissolving firstly in plasma. Oxygen dissolved in plasma diffuses quickly into the erythrocytes where it is combined with hemoglobin. Hemoglobin compounds with oxygen is called oxyhemoglobin. It is unstable and easily decomposes into hemoglobin and oxygen in tissues. And 1 gram of hemoglobin may bind 1.34 millimeters of oxygen. And such indexes is called oxygen capacity of hemoglobin in normal conditions. When hemoglobin content in blood, for example, is 150, it can bind 200 millimeters of oxygen approximately. So 150 we multiply into 1.34 millimeters and we got 200 millimeters of oxygen. This is oxygen capacity of arterial blood, so of whole blood. And indexes characterizing the intensity of oxygen usage by tissues is the arteriovenous difference and the oxygen utilization coefficient. Arteriovenous difference is the difference of oxygen content in arterial and venous blood. Since arterial blood contains about, as we said previously, 200 millimeters of oxygen, and venous blood contains 130-140 millimeters of oxygen at rest state, then arteriovenous difference is range from 60 to 80 millimeters per 1 liter of blood. Oxygen utilization coefficient is the percentage ratio of arteriovenous difference to oxygen content in arterial blood. And in the norm, this coefficient should be ranges within 30-40%. Now let's move to the next item of today's topic, which is oxygen hemoglobin dissociation curve. So what is it? This curve describes the percent saturation of hemoglobin in the blood at different blood partial pressure of oxygen. So hemoglobin is 100% saturated with oxygen when 4 oxygen molecules are bound to each hemoglobin molecule in the blood. So there are 4 heme groups in a hemoglobin molecule, and an oxygen molecule is bound to each heme group. Hemoglobin is 50% saturated with oxygen when there is an average of 2 oxygen molecules bound to each hemoglobin molecule. So the partial pressure of oxygen in the blood leaving the pulmonary capillaries normally is 104. You can see that here is 104 millimeters mercury. At that partial pressure, hemoglobin is 98% saturated. You can see on this graph that oxygen is 98% saturated. Decreases in the partial pressure of oxygen in the pulmonary capillaries have a relatively small effect on hemoglobin saturation, as shown by the fairly flat shape of the upper part of the oxygen hemoglobin dissociation curve. So even if blood partial pressure of oxygen decreases from 104 millimeters mercury to, for example, 60 millimeters mercury, hemoglobin is still 90% saturated. Hemoglobin is very effective at picking up oxygen in the lungs, even if the partial pressure of oxygen in the pulmonary capillaries decreases significantly. In a resting person, the normal blood partial pressure of oxygen leaving the tissue capillaries is 40. Leaving tissue capillaries. And hemoglobin at this level is 75% saturated. Those 23%, which means 98% of oxygen minus 75, and we will get 23%. So 23% of oxygen picked up in the lungs is released from hemoglobin and diffuses into tissues. The 75% of oxygen still bound to the hemoglobin is an oxygen reserve which can be released if blood partial pressure of oxygen decreases further. In the tissues, a relatively small amount in partial pressure of oxygen results in a relatively large change in hemoglobin saturation, as shown by the steep slope of the oxygen hemoglobin dissociation curve. For example, during vigorous exercise, partial pressure of oxygen in skeletal muscles, capillaries can decline to the levels as low as 15 millimeters mercury because of the increased use of oxygen during aerobic respiration in skeletal muscles. At the partial pressure of oxygen of 15 millimeters mercury, hemoglobin is only 25% saturated, resulting of 73% of the oxygen picked up in the lungs. Thus, as tissue use more oxygen, hemoglobin releases more oxygen to those tissues, which is seen from this graph. What are the parameters which can affect oxygen dissociation curve? So, in addition to partial pressure of oxygen, blood pH and partial pressure of CO2 and temperature influence the degree to which oxygen binds to hemoglobin. So here you see different graphs which describe effect of pH on the oxygen hemoglobin dissociation curve, effect of temperature, effect of partial pressure of CO2, and effect of 2.3 diphosphoglyceride on the hemoglobin dissociation curve. So as the pH of the blood declines, the amount of oxygen bound to hemoglobin at any given partial pressure of oxygen levels also declines. This occurs because decreased pH results from an increase in hydrogen ions, and the hydrogen ions combine with the protein part of the hemoglobin molecule and change its three-dimensional structure, causing a decrease in the hemoglobin's ability to bind oxygen. Conversely, an increase in blood pH results in an increase in hemoglobin's ability to bind oxygen. The effect of pH on the oxygen hemoglobin dissociation curve is called Bohr effect, after its discoverer Christian Bohr. An increase in partial pressure of CO2 also decreases hemoglobin's ability to bind oxygen because of the effect of carbon dioxide on pH level. So as carbon dioxide level increases, more hydrogen ions are produced and the pH level declines. As carbon dioxide levels decreases, the reaction proceeds in the opposite direction, resulting in a decrease in hydrogen ions concentration and an increase in pH. Those changes in carbon dioxide levels indirectly produce a Bohr effect by altering pH. In addition, carbon dioxide can directly affect hemoglobin's ability to bind oxygen to a small extent. When carbon dioxide binds to the alpha and beta globin chains of hemoglobin, hemoglobin's ability to bind with oxygen decreases. This effect is called Holden's effect. As blood passes through tissue capillaries, carbon dioxide enters the blood from the tissues. As a consequence, blood carbon dioxide level increases, pH decreases, and hemoglobin has less affinity for oxygen in the tissue capillaries. Therefore, a greater amount of oxygen is released in the tissue capillaries than would be released if carbon dioxide were not present. And the effect of temperature. So an increase in temperature, in case of, for example, fever, also decreases oxygen's tendency to remain bound to hemoglobin. Elevated temperatures resulting from increased metabolism therefore increase the amount of oxygen released into the tissues by hemoglobin. In less metabolically active tissues, in which the temperature is lower, less oxygen is released from hemoglobin. Carbon dioxide is continually produced as byproduct of cellular respiration, and the partial pressure gradient is established from tissue cells to the blood within the tissue capillaries. The intracellular partial pressure of CO2 is 46, approximately 46. As you can see from this picture, partial pressure of CO2 in the cells is 46. And the interstitial fluid concentration of CO2 is 45. At the arterial end of the tissue capillaries, the partial pressure of CO2 is close to 40. As blood flows through the tissue capillaries, carbon dioxide diffuses from higher partial pressure of CO2 to a lower partial pressure of CO2 until the equilibrium of partial pressure of CO2 is established. At the venous end, partial pressure of CO2 is equal to 45 millimeters mercury. After blood leaves the venous end of the capillaries, it is transported through the cardiovascular systems into the lung, and the arterial end of the pulmonary capillaries, partial pressure of CO2 is equal to 45 millimeters mercury. Because the partial pressure of CO2 is approximately 40 in the alveoli, you can see from this picture, it's 40. Carbon dioxide diffuses from pulmonary capillary into the alveoli. At the venous end of the pulmonary capillaries, partial pressure of CO2 has again decreased to 40 millimeters mercury. Carbon dioxide is transported in the blood in three ways. 7% of carbon dioxide dissolved in the plasma. Approximately 70% is in the form of HCO3 dissolved in plasma and in the red blood cells, and approximately 23% is bound to hemoglobin. Now let's move to the next item of today's topic is converting of CO2 to chemically bound forms. So in the tissues, carbon dioxide diffuses into the plasma and into the red blood cells. Some of the carbon dioxide remains in the plasma. In the red blood cells, carbon dioxide reacts with the water to form carbonic acid, H2CO3, in reaction catalyzed by the enzyme which is called carbonic anhydrase. Carbonic acid then dissociates to form bicarbonate ions and hydrogen ions. In the chloride shift, as HCO3 move out of the red blood cells, electrical neutrality is maintained by the movement of chloride ions into them. Oxygen is released from hemoglobin. Oxygen diffuses out of red blood cells and plasma into the tissue cells. Hydrogen ions combine with hemoglobin, which promotes the release of oxygen from hemoglobin, and this effect is called Bohr effect. Then carbon dioxide combined with hemoglobin, and hemoglobin that has released oxygen readily combines with carbon dioxide. This effect is called Holden's effect. Reverse conversion of CO2 in tissue. So, in the lungs, carbon dioxide diffuses from red blood cells and into the plasma and into the alveoli. Carbonic anhydrase catalyzes the formation of CO2 and H2O to form H2CO3. Bicarbonate ions and hydrogen ions combine to replace H2CO3. In the chloride shift, as HCO3 move into the red blood cell, electrical neutrality is maintained by the movement of chloride ions out of them. Oxygen diffuses into the plasma. Oxygen diffuses into the plasma and into red blood cells. Some of the oxygen remains in the plasma. Oxygen then binds to hemoglobin. Hydrogen ions that are released from hemoglobin promotes the uptake of oxygen by hemoglobin. This effect is called, as we already know, Bohr effect. Carbon dioxide is released from hemoglobin, and hemoglobin that is bound to oxygen is readily releases carbon dioxide, which is called Holden's effect. So now let's move to the next big group of subtopics of today's lecture, which is called regulation of respiration. So medullary respiratory centers. So first is pre-Botzinger complex. Pre-Botzinger complex is a neuron cluster located in the upper part of medulla oblongata, which is likely acting as a generator of basic respiratory rhythm. It is supposed the neurons of this complex have ability to autorhythmic activity similar to those as cardiac rhythm pacemakers, and periodically stimulate the neurons of dorsal respiratory group. So dorsal respiratory group, what is it? It's a main structure of respiratory center located in the dorsal part of the medulla oblongata, whose neurons are directly connected with spinal motor neurons innervated the inspiratory muscles. That is why neurons of this group are being considered as inspiratory neurons, providing an inhale. The finishing of their excitation leads to inspiratory muscles relaxation and creates the conditions for the followed exhale due to elastic lung forces. Some neurons of this nucleus receive and afferent information about the state of respiratory structures and blood gases from mechano- and chemoreceptors and modulate the inspiratory neuronal activity. Dorsal respiratory group can change the activity of neighboring ventral respiratory groups neurons, and however, in turn, it is controlled by EBAU-located structures of respiratory centers at pons level. So next group, which is called the ventral respiratory group, contains clusters of neurons in ventral part of the medulla oblongata, which are functionally divided into inspiratory and expiratory neurons. This group has low activity during calm breathing, but it becomes active being stimulated by dorsal respiratory group and involves the spinal cord motor neurons to the respiratory act control. Spinal motor neurons innervating accessory inspiratory and expiratory muscles provide enhanced or forced ventilations of the lungs. There is a scientific data about the participation of ventral respiratory group in the regulation of throat and larynx muscle tone, maintaining upper respiratory tract in the opened state. In particular, the sleep apnea, snore, etc. can be possible if the activity of these neurons are insufficient. Next one is Pneumothexic Center. It is a cluster of neurons located in lower part of the pons, maintaining prolonged excitation of dorsal respiratory group inspiratory neurons during an inhale. They are responsible for a special type of breathing which is called apneistic breathing. It is characterized by prolonged deep inhale, a delay of breathing at height of inhale, and the forced exhale finishing respiratory cycle. However, apneistic breath is being turned out only during certain terminal states in case of agony or deep hypoxia, since the apneistic center in the norm is inhibited by a neighboring pons structures called Pneumothexic Center. So Pneumothexic Center inhibit apneistic center. So now let's talk about this Pneumothexic Center. So the Pneumothexic Center is a main structure of respiratory center at the level of upper part of varolii pons, which coordinates delicately dorsal respiratory group activity with other body function, thermoregulation, sexual function, emotional state, sound production, and others. There is close bilateral integration of pneumothexic center with other CNS structures such as cerebral cortex, limbic system, hypothalamus, and others. The pneumothexic center directly affects the dorsal respiratory group, terminating the inspiratory neuron excitation and completes the inhale. The inhale duration can be changed in such way from 0.5 to 5 seconds, what results in the change of respiration rate from 5 to 40 excursions per 1 minute. Therefore, the brainstem respiratory center generates basic respiratory rhythm and modulates it in accordance with afferent information from receptors and efferent information from about located INS structures, coordinating respiration with the other vital body function. So what are the mechanoreceptory respiratory reflexes? So first one is Coring-Breuer reflex. The physiological significance of the Coring-Breuer reflex is to limit respiratory excursions and to prevent lung extension. This ensures that the depth of respiration corresponds to the needs of the body in the most economical mode. Second mechanoreceptor respiratory reflex is called reflexes from intercostal muscles. Intercostal muscles, like all other transversally strained muscles, have receptors for stretching, muscular spindles. In that case, if breathing or exhalation is difficult, the spindle of the corresponding muscles is excited and causes a reflex enhancement of the contraction of these muscles. Due to these features of intercostal muscles, coordination of mechanical parameters of respiration with elastic resistance of the respiratory system is achieved. In addition, the afferent information from the muscle spindles enter the respiratory center and provides appropriate change in the activity of other respiratory muscles. And the next one is reflexes from the receptors of the motor apparatus. These reflexes are manifested in increasing pulmonary ventilation in response to passive and active limb movements. Next one is chemoreceptory respiratory reflexes. So what is it, chemoreceptors? These are specialized neurons that respond to changes in chemicals in solution. The chemoreceptors involved in the regulation of respiration respond to changes in hydrogen ion concentration, changes of partial pressure of oxygen, partial pressure of CO2, or both. There are central and peripheral chemoreceptors. So central chemoreceptors are located bilaterally and ventrally in the chemosensitive area of the medulla oblongata, and they are connected to the respiratory center. Peripheral chemoreceptors are found in carotid bodies and aortic bodies. These structures are small vascular sensory organs which are encapsulated in the connective tissue and located near the carotid sinuses and the aortic arch. These receptors respond mainly to the changes of partial pressure of oxygen. The respiratory center is connected to the carotid body chemoreceptors through the glossopharyngeal nerve and the aortic body through the vagus nerve, 10 nerves. So what are the effects of pH on chemoreceptors? So the chemosensitive area responds indirectly to the changes in blood pH, whereas carotid and aortic bodies respond directly. Hydrogen ions do not easily cross the blood-brain barrier to affect the chemosensitive area, but they do easily cross from the blood to the carotid and aortic bodies. The chemosensitive area detects changes in blood pH through changes in blood carbon dioxide, which easily diffuses across the blood-brain barrier. For example, if blood carbon dioxide level increases, carbon dioxide diffuses across the blood-brain barrier into the cerebrospinal fluid. The carbon dioxide combines with water to form carbonic acid, which dissociates into hydrogen and HCO3. The increased concentration of hydrogen ions lowers the pH level and stimulates the chemosensitive area, which then stimulates the respiratory center, resulting in greater rate and depth of breathing. Consequently, carbon dioxide level decrease as carbon dioxide is eliminated from the body and blood pH increases to normal levels. What is the effect of carbon dioxide on chemoreceptors? Blood carbon dioxide levels are a major regulator of respiration during resting conditions and conditions when the carbon dioxide levels are elevated, for example, during intense exercise. Even a small increase in carbon dioxide in the circulatory system triggers large increase in the rate and depth of ventilation. An increase in partial pressure of CO2 of 5 millimeters mercury, for example, causes an increase in ventilation in 100%. A greater than normal amount of carbon dioxide in the blood is called hypercapnia. Conversely, lower than normal carbon dioxide level is called hypocapnia. Results in periods in which respiratory movements are reduced or do not occur. The chemoreceptors in the chemosensitive area of the medulla oblongata and in the carotid and aortic bodies respond to changes in carbon dioxide because of the effects of carbon dioxide on blood pH. The chemosensitive area in the medulla oblongata is far more important for the regulation of partial pressure of CO2 and pH than are the carotid and aortic bodies. The carotid and aortic bodies are responsible for at most 15 to 20% of the total response to changes in partial pressure of CO2 or pH. During intense exercise, however, the carotid bodies respond more rapidly to changes in blood pH than does the chemosensitive area of medulla oblongata. What is the effect of oxygen level on chemoreceptory? A decrease in oxygen levels below normal values is called hypoxia, and within normal range of partial pressure of oxygen levels, the effect of oxygen on the regulation of respiration is small. Only after arterial partial pressure of oxygen decreases approximately to 50% of its normal value does it begin to have a large stimulatory effect on respiratory movements. At first, it is somewhat surprising that small changes in partial pressure of oxygen do not cause changes in respiratory rate. But consideration of the oxygen hemoglobin dissociation curve, however, provides an explanation. So if we remember this oxygen dissociation curve, because of S shape of the curve, at any partial pressure of oxygen above 80 millimeters mercury, nearly all of the hemoglobin is saturated with oxygen. Consequently, until partial pressure of oxygen levels change significantly, there is only little effect on the oxygen carrying capacity of the blood. The carotid and the aortic bodies respond to decreased partial pressure of oxygen with increased stimulation of the respiratory center, which can keep it active despite decreasing oxygen levels. If partial pressure of oxygen decreases sufficiently, however, the respiratory center can fail to function, resulting in death. Next one is influence of non-specific factors on breathing. So what are these non-specific factors which can affect our depth and rate of breathing? This is a changing in the temperature. It can enhance ventilation, especially contrast bath in children. Pain reception, they can enhance ventilation. An increase in blood pressure depress both the inspiratory and expiratory neurons of the respiratory center, resulting in a decrease in the frequency and depth of breathing. The action of some hormones, like adrenaline and progesterone, they can increase respiration. Protective respiratory reflexes arise when irritating substances, which are called irritants, fall into the upper or lower respiratory tract. In the first case, the reflex is manifested in the form of sneezing, and in the second case in the form of coughing. A special kind of protective respiratory reflexes is the temporary cessation of respiration when the volatile poisonous substances enter the respiratory tract. Next one, reflex caused by G receptors stimulation. These receptors are located in the interstitial space of the alveoli and in the wall of the capillaries and react to the increase in the pressure of the intercellular fluid, which is observed with the threat of pulmonary edema. The reflex response to stimulation of the G receptors is to accelerate respiration, which is called tachypnea, and dry cough. At the same time, breathing is perceived subjectively as difficult and accompanied by a pressing pain in the chest, dyspnea. Voluntary control of respiration is possible due to representation of inspiratory and expiratory muscles in the motor cortex, anterior central gyrus. And the last item of today's topic is the regulation of breathing when found underwater at a great depth. So, some professionals are faced with the necessity to work underwater at a relatively large depth, several dozens of meters, for a long time. Such a situation creates the significant risks for health because of very essential deviation of indices of alveolar air and blood gas composition from the norm. The reason for this is an increased pressure on the body tissues created by the column of water above the immersed person. Thus, at a depth of 10 meters, the human breathes under the pressure 2 atmospheres without special underwater equipment. Every next 10 meters, add 1 more atmosphere to this pressure. The partial pressures of all alveolar gas mixture components are becoming several times higher compared to surface. According to Henry's law, dissolved gas tension and content are rising at the same times. It applies not only to oxygen and carbon dioxide, but also to nitrogen, whose solubility is very low during normal atmospheric pressure. So the consequences are followed. Narcotic effect of nitrogen and its oxides, which causes a special condition of euphoria similar to alcohol intoxication and disorders of consciousness. They begin to appear when a person is immersed at a depth of 30-40 meters and stays there for more than 30 minutes. Next one is toxic effect of hyperoxymia. Is associated with the formation of a large number of free oxygen radicals in tissues that damage lipid membranes of cells. In addition, the production of surfactants in the lungs is reduced, and the secretory function of the epithelium of the respiratory tract is disturbed. Next one is toxic effect of hypercapnia, on respiratory center, which begins to manifest when CO2 tension reaches more than 70-80 millimeters mercury. In this case, hypoventilation occurs instead of breathing stimulation. So incorrect rapid decompression means lifting of the human from death to the surface, is very dangerous. Sudden lowering of the solubility of all gases leads to their removal from blood in the form of microvesicles embolizing the small vessels of all tissues. This state has been called as caisson disease, so microembolization of vessels with air bubbles with rapid decompression. Its symptomatic depends on the embolization place, but most often manifests itself as loss of consciousness and disturbances of cardiovascular and nervous systems. The treatment of this disease consists in placing the patient in special decompression hermetic chambers where the pressure close to that under which the patient was staying at death is being created and slow decompression is being carried out. Small decompression means several hours for removing of person from that chamber. So this is all for today's topic. Thank you for your attention.